We're in business. Hey there, folks, and good evening. Top of the evening to you, and happy Tuesday. I'm Dr. Randy Fink, and it is time for Fertility with Fink. We are in the right place every Tuesday evening at this time. 5 o'clock on the Gulf Coast, which means 6 o'clock on the East, 4 o'clock in the mountains, and 3 on the West. And this is the time that we get together every single week to talk about all those things that are important to us. And I want to say a very happy Tuesday evening to all of you. I hope your weekend was great. Hi, Sarah. We've got a few different feeds here. Hi, Crystal. Nice to see you. We've got New Life Fertility's Instagram over here. We've got Facebook, a couple of different Facebooks for New Life and for MCRM. We've got LinkedIn. We've got YouTube. We've got my Instagram, which is right here, and that's Randy Fink MD. Please feel free to follow me. I hope you will. We try to put some content up that interests and entertains you, and I've got a real interesting one that's going to go up tomorrow. But in the meanwhile, I am a fertility gynecologist here at New Life Fertility in Pensacola, Florida, and I also work with some wonderful folks, my colleagues at the Missouri Center for Reproductive Medicine in St. Louis, and also at their office in Tulsa. We here on the Gulf Coast have offices in Pensacola, in Mobile, Alabama, and in Panama City. Any of us can see you at any of our locations. We can do that virtually, we can do that remotely, and we can help you get to where you want to be. So how is it going? Let's see what who else we have joining. The Bama Gal joined there along with Marlena. You may recall last week when we did our 5:30 fuzzies with Fink, we sent some, you all were kind enough to send a special greetings out to my dear mom who was in the hospital at the time. And I'm very happy to say that she came home from the hospital. Thank you, Rosa, so much for asking there. She came home from the hospital just yesterday and is so much happier to be at home than in the hospital. I can't even begin to tell you, but you can probably imagine hospitals are not a place that most people really enjoy being very much, and rightly so. Even if you work there, it may not be someplace that you necessarily really enjoy being. But Mom, you are the first to join my program this evening, so thank you, and thank everybody who sent those wonderful well wishes to my beautiful mother. Marlena, howdy. Vital Drip, it looks like. A. Clark. We've got, Rosa says, good news. Hi, Nicole Biggs. Nice to see you there. Stephanie, hello there to you as well. We got a bunch of people I see already over here on the Facebook side, but it doesn't tell me who you are. So thank you very much for being here. This is the opportunity we have to answer questions and to talk about all kinds of interesting things. Hi, Noodles for Life. And hello to Sadie Ann. We get a chance to answer your questions. So if you have a question, anything you want to talk about, please throw it out there to me. I got to say, I'm going to give you a little preview of a post I'm going to put up tomorrow. So, when we talk about supplements, my favorite supplement as far as getting pregnant goes is certainly CoQ10 because of its effect on the ovary and on egg quality. But I have a very close second running behind that, very close second, and that is, excuse me, and that is alpha lipoic acid, or ALA. Alpha lipoic acid is also a very inexpensive supplement that you can get from any drugstore, any pharmacy, grocery store, any place that sells vitamins. And what it is an antioxidant. So it helps us with what's known as oxidative stress, but it really helps to heal potentially damaged tissue. This is especially true at the level of the ovaries, but there are two very important uses for alpha lipoic acid, and this is what I'll call attention to in the post that I'm going to put up tomorrow. One has to do with male fertility, and in a recent study, we found that 600 milligrams of alpha lipoic acid a day doubled the pregnancy rate in a group of men in couples who were trying to get pregnant. So it had such profound effects on sperm parameters that the pregnancy rate in that study literally doubled. That's pretty impressive stuff. The other use for alpha lipoic acid happens in people who are already pregnant. And that is, as you know, some people, when pregnant, will have some bleeding. Bleeding in early pregnancy in the first trimester can happen due to, a kind of a number of different reasons. But one of the more common reasons is something that's known as a subchorionic hematoma or a subchorionic hemorrhage. Subchorionic hemorrhage is literally a collection of blood that sits beneath the placenta. And how does it get there? Well, as the uterus starts to grow and it moves, the placenta moves along with it, and it can shear off a little space that's underneath. Most of that blood, like any other bruise, most of that blood will get reabsorbed. So if I, get punched in the arm, you see it turns different colors, and eventually that bruise goes away. But some of it is close to the cervix. Some of it happens to just kind of go out the door. And so that's what causes that bleeding. Alpha lipoic acid, also at 600 milligrams a day, has been shown to decrease the amount of bleeding and to more rapidly resolve a subchorionic hematoma when used with progesterone, which most of our patients are using if they have done fertility treatment. So I would tell you alpha lipoic acid is probably a really good thing. Dirt cheap, get it any place. Marlena says, holy moly, sounds like our partners should all be using LA. And I think the answer to that is yes. There is no good reason not to, given what we've learned about it. Noodles asks, my lining is not responding after suppression. I took Provera to induce a period to restart an FET cycle. Still no period. Any hope? 10 days after the last dose of Provera. So the first question I would ask their Noodles is, well, how thick is the lining? Because have you grown a lining? Because if you got Provera, so Provera requires that you have a sufficient enough estrogen level that you grew some lining so that then when you stop it, it will cause you to slough off that lining. If the lining simply just never really grew, then progesterone is going to make you slough off nothing. So there's really nothing that's there. So I'd want to know how thick is that lining. And you say the lining was 6 millimeters. So there's probably a little bit there. So sometimes what happens with Provera is that since you're taking it orally, it may not be a sufficient enough dose to get you to have a withdrawal bleed. So usually the next thing that I would do is say, just get a PIO shot, just get 75 milligrams of PIO, or even, you want to do it for real, get 150 milligrams of progesterone in oil. And that will almost always do it. There are some practices who will never really use Provera because of its oral absorption, that they worry that it's not, going to kind of be enough to be able to get people to have the bleed. And they will always do a shot instead, because the shot almost always works. But 6 millimeters is enough lining that it should be something there to slough off. So that's kind of really what I would do. So is there any hope? The answer is, oh yeah, Noodles, absolutely. There is hope for sure. Crystal asks, how long before and during FET do you stay on supplements? So usually for an embryo transfer, I recommend you get on the supplement protocol when you start your medication. So typically when you start your estrogen, that's a good time to kind of start the evidence-based protocol. And that protocol is prenatal vitamin, vitamin D, vitamin E, CoQ10, and L-arginine, which is an amino acid, at 6 grams a day. So that's the ones to start. And I would say, how long do you stay on them? Stay on them until you get a positive pregnancy test. Then the two things that I'd want you to consider when you have that positive pregnancy test are prenatal vitamin and fish oil. Those are really the only two things that you have to stay on. Hey, Miss Nurse Practitioner Foxy, thank you for being here this evening. It's nice to see you as always. Let's see. Rachel says, where can I get CoQ10 600 milligram, the drugstore, or, well, yeah. So here's the thing. There are two types of CoQ10. One is called ubiquinol, and the other is called ubiquinone. Ubiquinol and ubiquinone. Ubiquinol is the form that your body naturally uses CoQ10, whereas ubiquinone is a different form that your body has to convert in order to get it to go to work. So if you're getting ubiquinol, you need 400 milligrams, so usually a 200 milligram tablet, and you take it twice a day. If you are getting ubiquinone, then you need to be on 600 milligrams, so typically 300 milligrams twice a day. Now, sometimes it's just easy to get a 400 milligram tablet there, Rachel, or capsule rather, a 400 milligram capsule. There is no harm to taking 800 milligrams a day. You can't get too much of it, but if that's easy and cheap, and that is important, it needs to be both easy and cheap. I would, I'd say just get a little bit higher of a dose, and that's not a problem at all. Sarah asks, on 90 days of Lupron and letrozole suppression, is there harm to doing IM estrogen right away instead of pills? Worried I won't grow a lining well. So the injectable estrogen is called del-estrogen, and it's really inexpensive. So is there a harm to doing that? Typically, you do an injection every 3 days. I would say that there's no harm to doing it. I would still recommend that you use either estradiol orally or that you use a patch as well, but you can certainly supplement that with del-estrogen. And ultimately, it really works for almost everybody. And actually, going back over here to noodles, that would be also an easy solution in another cycle for you as well, if you needed to. The injectable estrogen every third day. So is there harm to doing that? No, certainly no harm. And hi, Andre, nice to see you. Haven't seen you around for a while. She asks, are there any benefits for Omnitrope with low AMH and DOR patients, or would you recommend rapamycin? Well, so the thing about Omnitrope or growth hormone is that it's just really not well, I won't say it's not well studied, but the evidence is not really all that strong that it does wonders. Now, it's the thing that we've always turned to. So for people with diminished ovarian reserve and potentially egg quality issues, we would always say, well, let's take some growth hormone, because it's growth hormone that keeps us young. So if we get some extra growth hormone, that maybe we're helping our bodies to repair some of that age-damaged DNA at the level of the eggs. The problem is that, the studies just really haven't shown that Omnitrope does wonderful things. Now, I use it all the time, and I think it does good things for some people. It just doesn't do good things for all people. So what that ultimately means is that I think we just haven't identified the perfect group for whom Omnitrope is going to work. Now, if you've used it before and it did good things for you, absolutely go ahead and use it. It's just so freaking expensive, It's really expensive. And the other thing you asked about there was rapamycin or sirolimus. And that, I think, I've had really, really good results with. There's very good evidence that using sirolimus for egg quality makes a difference, both in terms of the quality of the eggs retrieved, the quality of the embryos that are made, and ultimately even in the live birth rate. And sirolimus is inexpensive. It's covered by everybody's insurance. You get it in any drugstore. It's not this, multi-$100 affair that comes from, having to use Omnitrope. So I feel very good about sirolimus or rapamycin. What it does, and this is kind of the way I explain what it does. So we talked about growth hormone. hormone and the way it may help, because growth hormone keeps us young. So maybe it keeps us young at the level of the ovaries too. But one of the things that happens as our cells start to age is that things start to happen a lot more quickly in the cells. Things happen a lot faster in terms of manufacturing proteins and doing all this metabolic stuff that that eggs and embryos and all that stuff that they do. It just happens faster and faster. And you know what happens to you and me when we start doing things that are too fast? We start making mistakes. And the same thing happens in the body. So what sirolimus or rapamycin does is that it taps the brakes. It just slows things down a little bit and lets the body catch up on itself. And since there's pretty good evidence that it does help with fertility, I would say, to me, my money is more on sirolimus. Now, if you can do both of them, if you can do both, rapamycin and omnitrope, then I think you're covering, many bases. But omnitrope is out of reach to a lot of people because it is just so expensive. And the problem is, again, in some people, it makes a huge difference. And forever, that's really all we had to offer people. In some people, it makes a great difference. And in other people, it just doesn't do anything at all. And when you look at the studies, it says really what it does is adds cost to your retrieval, which means, all right, yeah, some people it's going to work for, some people it's going to help, but some people it's not. And so identifying that cohort, identifying the group of people, where it's going to make a difference, that's, just still a little bit elusive to us right now. Let's see. Oh yeah. So Andre says, yeah, I tried it and I didn't see any benefit. So to the presumably talking about the omnitrope. So I would say yes, absolutely, rapamycin. So it's about, it may be $10 on your insurance, even if your insurance doesn't cover it. If you use the Good RX coupon, it's like $35 or $28, depending on kind of where you are. So you can look it up there, and yeah, I would definitely recommend it. Priest Lana, hello, and Paulinda, I think that says. And who do we have over here? Amazing Javier, and good evening, Angela. Nice to see you this evening. Thank you for joining. Used to be on prednisone in past transfers, but now they changed it to Medrol packs for 6 days. Wouldn't I need to be on longer if a positive pregnancy test? I have a positive ANA and some autoimmune things. Well, so I think the reason that, Angela, I believe you're a CNY patient, and I've been talking to a number of CNY patients recently, done some consults with, and I think Dr. Kiltz now likes using a Medrol dose pack. I haven't talked to him, so I don't know what made him change his tune on that, but they're basically the same thing. The difference is that the dose pack, the Medrol dose pack, basically tapers you off your prednisone. It tapers down. And so you're not supposed to get big doses of steroid and then just stop them automatically. Because if you stop them, if you just cut them off, it can really adversely affect, can make you feel like hell, first of all, but also can really adversely affect your adrenal glands, which are your cortisol making glands. So the dose pack gives you that taper, and so you don't have to do it manually. And yes, you are right. With a positive ANA, the best evidence is that you are on, well, actually, the evidence says that you're on both Plaquenil or hydroxychloroquine and prednisone during your transfer. Now, it doesn't specifically say, well, if that's just a dose pack or if that's just, it may be that a single slug of steroid over a shorter period of time is enough to suppress the immune system there. Still, I think that, I think it's a matter of preference. Using one versus the other, and at least if you're using a Medrol dose pack, that you're going to get the taper done correctly. If someone in the, let's say, nursing department forgets gets to tell you to taper it and you just stop it, you know that you'll get the taper if you're using the dose pack. But I'm not aware of the specific evidence that says you need to stay on it during pregnancy, because usually we would start to taper that off by 10 weeks anyway, so that you're done with it when you finish the first trimester. Now, yeah, and again, my guess is there that the evidence would show, and I don't think it's actually been studied, but because prednisone was the original studied thing, but I think probably just getting that initial hit of steroid is enough to give you the immune suppression. So, maybe there's something to doing it for a shorter period of time. Heavenly Joy and Kimmy Girl, good evening. Thanks for being here. Amazing Javier says, well, hey, when does Trump's IVF access thing become effective? And I don't know the answer to that, because I was on the phone with the president just the other day, and we had other things to talk about. There's a lot going on in his world right now. I'm kidding. I'm not sure, but I think it's probably sometime soon, because the pharmaceutical companies are talking about it, people are talking about it, and costs are going down for these medications. So that's good news. Hey, Christy Almanza, it's Ming. Howdy. Dr. Fink, is metformin recommended during transfer? I've heard a lot of patients say it is. So metformin is specifically used in folks with polycystic ovarian syndrome or with insulin resistance. So if you are using metformin and you have polycystic ovarian syndrome, it both increases the success rate of your transfer and decreases the risk of miscarriage. So that sounds like a pretty good plan to me. However, there is not really very good evidence that metformin is helpful in transfers for people who don't have insulin resistance and polycystic ovarian syndrome. So if you've never been given that diagnosis, I would not say that you should be on metformin. Metformin, it's a good drug. It is a good thing. But it's hard to take, and anybody who's taken it before can tell you. And the reason for that is that it causes, its most common side effect is GI related side effects. So it's stomach stuff. It's bloating, gassy, diarrhea, and sometimes nausea. And that sounds like a joy. Sounds like my work day every day, right? Just kidding. I'm not gassy at work. The reason for that, the reason that it does that is because, what metformin is doing is that it's driving sugar into your cells, driving sugar into the cells. The most sensitive cells that we have in our bodies are those cells that line our GI tract. And so when you drive sugar into those cells, it may start to damage those cells and they start to slough off. And it's that sloughing of GI cells that causes those GI side effects. That's the very reason why some people, folks who have to use chemotherapy, when they're on chemo, they get, diarrhea and nausea, vomiting, because it starts to, those cells that line the GI tract are the first ones to go. Now they get replaced, ultimately they do grow back, but when you're driving sugar into those cells and it's damaging those cells and they're sloughing off, that's the reason that when you start using metformin, you're on the toilet all day. Now, one thing that you could do there, Ming, and that is there is a supplement that functions very, very similarly to metformin, and that is known as inositol or myo-inositol. Myo-inositol is also available any place that you can get supplements. You get it online, you get it from Amazon, you get it from Fullscript, doesn't matter. You want to be taking at least 6 to 8 grams of inositol daily. Now, inositol comes in a powder and also comes in a capsule. To me, I think using the powder is very difficult. I don't like having to mix stuff up in liquid and then drink it. I think that makes it kind of gross. But capsules work better for me. Inositol, there is no harm to taking it. It doesn't have the same kind of side effects that metformin does. So let's say that you feel like metformin is really a good idea for you, but your doctor says, no, there's no reason for you to take metformin. I don't believe in that. I'm not giving you that. You can take inositol and it will really give you the same benefit. But again, really much more so for polycystic ovarian syndrome and for insulin resistance. Zenaida in Miami, thank you for being here. Good evening to you, my friend. Sydney asks, how long would I have to wait to do a retrieval and transfer after TKA? After TKA. I am not sure what TKA is there, Sydney. I apologize. If you want to throw that down here at the bottom, I'll keep watching for it and see if I can answer your question there. Hey, Shaylin and Lily. Emmy asks, is ultra low molecular weight heparin safe during pregnancy? And the answer is, I believe it is. So usually what we use in pregnancy is either simply sub-Q heparin or Lovenox, which is low molecular weight heparin. And what you're asking about is ultra low molecular weight heparin. So the costs just kind of go up as you get kind of more filtered sort of product there. But as far as I know, yes, it is safe during pregnancy if you have to be on a blood thinner. Sydney asks, total knee arthroscopy or knee replacement. Okay. All right. I got it. So if you are having a knee replacement, the knee replacement is a tough one. Knee replacement is a big surgery, even though now most of the knee replacements and the total joints that they do are really minimally invasive. They've come a long way in terms of how joint replacements are done. But there is still a lot of rehab involved, a lot of physical therapy, and there's a lot of inflammation that goes along with that. So I would not be really very enthusiastic about you doing an embryo transfer until probably at least, I'd say 4 to 6 months, I would think, after a total knee. Now, if you're doing an arthroscopy, if they're just going in to clean up, let's say, you got a torn meniscus or you've got an ACL, and they're going to do that arthroscopically, 2 months after that, I think is fine. You still have some inflammation there. But as far as egg retrieval goes, I think you can proceed with a retrieval a couple months afterwards and maybe an extra month, maybe 3 months after an arthroscopy. There's no hard and fast rule about that. But just think, inflammation can sort of stand in the way. Not so much in terms of the egg quality portion there, but really about, when you go to put an embryo back inside, really want your body to be as healthy and happy as it can be. Sorry for not knowing what TKA was. You had me thinking, is that something in fertility that I am supposed to know the answer to, and I'm just not thinking of it. Got it there. You got some friends chiming in over here on the new life side of things, total knee arthroplasty. Okay, thank you for the clarification there. Can you get a sonohystogram during or after an egg retrieval? And the answer is yes, absolutely. So when I do my work at MCRM in St. Louis, when we do egg retrievals, I'd say a large portion of those patients are having what we call a fluid ultrasound or a saline sonogram. A sonohystogram at the time of egg retrieval. So, yep, it's definitely very easy to do, and you don't even have to feel it, which makes things, really kind of all the better. Vanessa asks on the Facebook side, can a severe sinus infection requiring an antibiotic have a negative effect on semen? Well, I think the down and dirty answer to that, Vanessa, is yeah, I think it can. So first thing to know is that, sperm that comes out today was manufactured in his body 3 months ago. but that sperm has to go through all the tubing, all the piping in order to get out. It has to go through the prostate gland. It has to go through the seminal vesicles. It has to go through, all the different glandular structures that are supplying the other ingredients of semen. And those things are very subject to stuff happening in the immune system. So by the same token, if he's sick, we think that abnormal morphology in sperm, meaning to say when we look at sperm and we see that, the heads and the necks and the tails, they just don't look all normal here. They don't look right. And that's kind of a funny thing because we as humans, 96% of our sperm can be abnormal, and that's normal. What's normal is that only 4% of the sperm that we see are normal. That's what's called morphology. But I would say, it's thought that some of that morphology issue, when they're made abnormal, happens as a result of that sperm being transported through all that tubing. And so if there's some other inflammatory process going on in the body at that time, that may be sufficient to kind of mess with sperm. So I would say, yeah, it really probably definitely can. Let's see, what were we going to do here? Oh, guess what time it is? It's 1:30, which means it is time for the 5:30 Fuzzies with Fink. If it's not 5:30 where you are, then maybe it's 4:30 or maybe it's 6:30, but the Fink Fuzzy time happens at 1:30. And what is that? This whole fertility business is a difficult path to navigate. Not only is it tough to not know what's going to happen tomorrow, the unknown, the uncertainty associated with doing treatments, the pain of having to pay for treatments and to go through things like shots and watching the calendar and being stressed over all these things, it can be a very uncomfortable ride. Not only that, very commonly, people start to feel truly alone during the process. And even though you may go into your fertility clinic and you may see a waiting room full of people who are doing the same thing as you are, it may very much remind you of every decision that you've ever made in your life that you feel like was a mistake that got you to where you are now, and it feels very lonely. This group of people who watch this podcast are really, truly a special group. And I know that each one of you would, in a moment and in a heartbeat, really give the shirt off your back to somebody else who is in need, who is going through many of the same feelings that you have. So what we do at 1:30 here is to take a moment to just send out all the positive vibes we have, to stand together as one community, and to give each and every person out there, whether it's a fertility issue, a family issue, a relationship issue, a work issue, a financial issue, whatever it is you're going through, you got to know that you're not alone. We are all here with you, and we are all in this together. So please, let's break the internet with kindness right this minute. Send those positive vibes out to everybody tonight who needs them, because you are never alone on this journey in life. And that, my friends, is the 5:30 Fuzzies with Fink. Thank you for participating. And by the by, if you would, ask your friends to join in, even if it's like, 29 minutes past the hour next time, even if it's just for 2 minutes, because the more people that we can have here, I think really the bigger difference we can make in this world. Isn't that ultimately what we're all really trying to do here? Hi to Florida Mama Lynn's. Priest Lana says, prayers for positivity for everybody. Thank you very much for sharing those prayers. And let's see who else we got going on here. We have Rachel says, I'm 42 years old. How is the IVF success rate? So I have to tell you that, the more mature we are, the greater the challenges with IVF, because By 42, not only are we losing eggs at a pretty rapid rate, but all those eggs that you have in your ovaries have been there since the day you were born. And so the longer they sit there, the longer they have for that DNA to start to become unstable. Now, that absolutely doesn't mean that you can't get pregnant, because 100% you can. It just is a taller order. It means that as we retrieve eggs from you, there's a greater probability that the eggs that come from you will not be normal and will not make a normal embryo. And what we need is a chromosomally normal embryo in order to get that embryo to stick. So when I say an abnormal egg makes an abnormal embryo, that does not mean that you make an abnormal baby. What it means is that an abnormal embryo just typically doesn't stick and you don't get a positive pregnancy test. So the odds are lower, but they are definitely not zero. Most of the time, Rachel, what I would tell you is that, be realistic. And that is, it is probably going to take more than one cycle for you to get there. Realistically, it may take 3 cycles in order to get enough eggs to make enough good embryos to make to be able to give you, options for pregnancy. So a lot of it has to do kind of with your numbers. There is an evidence-based protocol. There are lots of other things that we can do, supplements and medication-wise, to try to improve egg quality. So the answer is yes, you can do it for sure. I'm sure there are people out there watching now who are 42 who have been through this and are holding their babies at this very moment. So in fact, I know that to be the case. But yes, it is doable. It's just, a little bit more of an uphill climb, and that's okay, because we know how to do that. Let's see what we got here. Got a couple more over there. Robin asks, so actually before we get to Robin, Brienne asks, have you heard of, or would you recommend letrozole as an alternative to methotrexate for ectopic pregnancy treatment? I have never heard of letrozole as a treatment for an ectopic pregnancy, because letrozole's mechanism is that it is taking your testosterone and it is blocking that conversion of testosterone to estrogen. And while certainly estrogen is a requirement for an embryo to grow, methotrexate is kind of pulling apart folic acid, which is a very important thing for structurally a pregnancy in order to be able to grow. So, like I say, I haven't heard of it, but ectopic pregnancies are scary things. I would be very hesitant to kind of start doing experimenting if I knew that I had an ectopic, because ectopics, people can have real problems from ectopic pregnancies. So be very careful there, if you would. Robin asks, have you treated anyone with Ehlers-Danlos syndrome, and are there any supplements or treatments that need to be done prior to trying for implantation? I have treated many a patient with Ehlers-Danlos, and many of them have gotten pregnant. So there is nothing specific about the Ehlers-Danlos syndrome that requires specific supplements as it pertains to pregnancy. But again, those really 6 most important ones: prenatal vitamin, vitamin D, vitamin E, CoQ10, L-arginine, and omega-3 or fish oil. And by the way, as an aside, if you're going to get the omega-3, get the one that says odorless or burpless, because it literally is wrung out from a sardine. And if you burp that up, it will cause the paint to peel off the wall, man. It is, it's pretty heinous. Yeah, you just don't want to go there. So best of luck to you, Robin. Let's see. Vanessa says we have an egg retrieval in April, but its results were very low today. Okay. Egg retrieval in April. Oh, maybe you're talking about sperm, because you say his morphology is less than 1%. So what does that mean? Well, so morphology, again, is what do the sperm look like under the microscope? And believe it or not, it's somebody's job to sit in a microscope all day long and look at heads and necks and tails of sperm. God bless them for the work that they do. Um, Morphology is something that may not be easily reproducible from one examiner to the other. You can show one semen analysis to one andrologist or technician looking at sperm, and they may come up with really a completely different number as somebody different. So it's not considered to be a cause of infertility. Rather, it is associated with subfertility in folks who are, being seen in a fertility clinic. So we could go out onto the streets there and do semen analyses from 100 different men. Probably get arrested in the act of doing that. But if we did that, we may find quite a bit of variability in the morphology of sperm, even in some people who have no issues getting pregnant at all. What it tells me when I see a question about morphology, it makes me start to wonder about, well, how intact is the DNA that's in those sperm? So in my practice, that is one indication for doing testing for DNA fragmentation. Because if the DNA fragmentation numbers are high, more DNA is starting to come unwound in those sperm, it means that those sperm will not do as good a job fertilizing an egg. When they go to knock on the door of the egg just may not be able to answer because the sperm can't penetrate that little shell. That's what I think of when I talk about morphology. It may have something to do with a decrease in the ability of a sperm to fertilize an egg. Let's see. Would you, this comes from Vital Drip by Laura. Would you want to use metformin or myo-inositol in patients with PCOS? And my preference is to actually use metformin because it's very potent. We know that metformin is manufactured under FDA guidance. It's a pharmautically manufactured drug. So we can say extremely confidently that every 2 pills are the same, and that every 2 bottles contain the same thing, and that they do in fact contain exactly what they say they contain because the government watches over the manufacture of that medication. With supplements, we can't say the same thing. They are not manufactured to FDA specifications. There really is no particular governing body that says how supplements should be manufactured. There's something called good manufacturing practices, but it still means there can be a lot of variation in these vitamins. And so the studies have shown us that if you pull 2 bottles of the same thing off the shelf and take a couple of pills from each bottle and then molecularly analyze them, you may find there is a wide variation in what's actually in those pills, and that what's in them may not be entirely what's on the label that says it's in them. And furthermore, the 2 bottles may not be the same at all. So, it's not that supplements aren't a good thing, because, hey, I wrote a book on it. I feel very strongly that supplements have their place. But really, if you have PCO and insulin resistance and we're going to treat you with something, I'm going to suggest that you use metformin, the medication, before I suggest you use inositol. So if you really have PCO, I think the medication, in my opinion, is the better way to go. Let's see. Rachel says my AMH is 0.25. So that is considered a diminished ovarian reserve. We don't want to do donor egg because of the culture issue. So what should we do? Any option? Yeah, man, absolutely. So 0.25, listen, that does not mean that you can't have a baby. That does not mean that you couldn't have a baby on your own. That certainly doesn't mean that you can't have a baby by IVF. It doesn't say anything about your egg quality. It doesn't say anything about when you're going to go into menopause. What it says is that we're going to have to be pretty aggressive in order to get your ovaries to respond to medication. And that's really the only thing that low AMH says to me. So it means you're probably going to need to do more than one cycle, because my guess is that if we looked at an antral follicle count, if we did an ultrasound and looked at your ovaries in the beginning of the cycle to see how many eggs, little egg houses are hanging out there waiting to get told what to do, it's probably not going to be a ton of them. That sort of goes along with that lower AMH. And so it means that, there may be fewer eggs each time for us to get, but all we need is one egg, friend. One egg makes one embryo, makes one baby. So I do not tell people with low AMHs that they should not do a cycle. Now, sometimes you do a cycle or even two or even three and find that, wow, you know what? It's just not working as well as I had hoped. And if that's the case, typically, then the writing's on the wall. Then that's the way you learn that, well, okay, this may not be the best choice for me. And then you kind of start thinking about other options. But even with an AMH of 0.25, there are tons of people with lower AMHs who get pregnant every single day. So don't let that stop you. Give it a try. Even if, and there's some other things there, Rachel, it depends on age, it depends on, some other stuff. But even if it's a closure cycle, meaning to say you want to do it because you want to be able to see how your body responds. And you may find it doesn't give you the answers that you want, but then at least then at least you have tried and you have done everything that you could do. So that's my 2 cents worth on that. Vanessa, you have an appointment with me on March the 6th. Oh, outstanding. 3 days from today. We'll look forward to seeing you. Maddie May asks, what's the ideal number of follicles when doing an initial ovarian ultrasound? So really it depends on age. There is an age-related nomogram to this thing that we call the antral follicle count. So what is the antral follicle count? In the beginning of your menstrual cycle, your brain says to the ovary, give me a bunch of eggs. And the ovary says, okay. And so it dips down into its well and it pulls up a bunch of little egg houses, or what we call follicles. And it's funny, we call it follicles. People are like, oh yeah, you're short of some follicles up there too, huh? And I'm like, okay, you don't have to call attention to that. Thanks. Say it out loud. Really? Follicles, unlike a hair follicle, are the little egg houses in the ovaries. They're literally a little tiny sac of fluid with a microscopic egg on the inside. Well, we can look, and so normally what happens in a cycle, those follicles will kind of come up to the surface and they fight with one another because one of them is going to be the one that goes on to get ovulated or to get released. And that's how you have a normal menstrual cycle. Well, we can look at those and we can physically count them. How many is there really kind of, and where that falls is going to be in a percentile. So generally speaking, if there are less than, let's call it 10 to 12, I'm going to say that's going to be a low amount at any age. And that's generally going to be, kind of at less than the 10th percentile. But some people have 15 follicles in each ovary, resulting in 30 follicles or 40 follicles. Well, that might turn out to be in the 97th percentile. That's a lot of follicles to have. And having all those follicles may not necessarily be a good thing, because as they're starting to fight with each other, they can start to change things hormonally. And that's one of the issues we have with PCOS. So, again, Maddie made the if you want to kind of really know the answer, you can just kind of Google what is, or ask ChatGPT or something, or you can go and find the little graph and it'll show you based on age What is the 50th percentile antral follicle count for age blank? And that shows you where you would fall if you were right smack in the middle. Does that matter? Do you have to be in the middle? If you're not in the middle, if you're on the lower third, does that matter? Is that a bad thing? I'm always hesitant to tell people to go to the internet to look stuff up because it creates a monster, and Dr. Google is really not necessarily your friend, because a lot of times that information is just overtly wrong, or you're not able to interpret it fully. So it doesn't matter what you have, because again, it only takes one. What this is really telling us is, well, what kind of expected response can we think about for using medication in a stim cycle? That's really what the antral follicle count does for me as a clinician. All right, let's see. Felipe, I'll get to you there in 1 second, sir. I had a couple of other things over here. Midgie asked, does the Zymote help to identify normal sperm? And the answer is Zymote theoretically helps the andrologist pick out better, stronger sperm for the in order to be able to fertilize an egg. So normally, an embryologist sits at the microscope and they select one individual sperm and they place that sperm inside each egg, and that's called ICSI. They ICSI the egg, they fertilize the egg. ICSI is intracytoplasmic sperm injection. They fertilize the egg with that sperm, and that is that's how it's done. What Zymote does is that, again, you may have heard me say this before. I describe it as a little obstacle course for sperm. They put the sperm through an obstacle course. They put them in on one side. It's like a little cartridge. You put them in on one side. Sperm swim through. The first sperm that come out the other side are the better and stronger sperm. They made it through the obstacle course sooner. So that means that the embryologist can sit there and select the individual sperm from a group of sperm that is already going to be the better sperm. So in theory, yes, Midgie, that's kind of what Zymote is designed to do, and that's what they claim it does. So we'll go along with that. Felipe says, I did my semen analysis and I was sick with a respiratory infection and lots of meds, and my analysis was low. Could that have a role in it? And I'd say, yeah, it definitely could. And when you do one single semen analysis, there is going to be a lot of variability in any sperm sample. So technically, to say that we have an abnormality, we want to do 2 semen analyses, because you may repeat it and it's completely normal because you just had a bad day. Because you were sick at the time that you did it. So I would say, yeah, I think it is, especially if it was abnormal, it's definitely worth saying, well, let's repeat it and see where we are. Now, unfortunately, there's a cost to repeating the semen analysis, but if it's going to make a difference in how you're getting treated, then I'd say it is really probably well worth it. So yeah, everybody is entitled to a bad day, even sperm, and that's why technically 2 semen analyses are required in order to make a diagnosis of male factor infertility or some problem that existed on even just one single semen analysis. Hey, Daisy, nice to see you this evening. How about vitamin E? Angela asks for an embryo transfer. Yes, vitamin E is on the list. Prenatal vitamin, vitamin D, vitamin E, CoQ10, L-arginine. You are exactly right. Yes, it does help with the lining. It helps with the blood flow. Hi, Amber and Megan. And Kimmy says, I just had my first failed embryo transfer with a day 5 AA, so excellent quality euploid. Oh man, I'm really sorry to hear that. That is so disappointing. And so frustrating because you had an excellent quality embryo, you had a tested embryo, which means that it's a 65% probability of pregnancy. But here's the thing to know. We know that euploid embryo from its testing, or at least we believe from its testing, that it was chromosomally normal. And chromosomes are the number one issue. That's the main reason if folks do an embryo transfer that those transfers don't stick. But it's not the only reason. And that's why we would quote you a 65% pregnancy rate with a single euploid embryo. It's not 100%. There are other things that can go wrong with that embryo biochemically, all those little chemical things that are happening in a million little chemical equations at any given moment. And any one of those things goes wrong, that embryo may not work. Now, Kimmy, there are some things that we start to do and start to look at when folks have had euploid transfers and they don't get pregnant. You might think about doing a receptiva, which checks to see is endometriosis standing in the way. To be honest with you, when you look at numbers, and if you were mine, we would have a conversation about some of these things if you elect to do them. Certainly, if you do 2 transfers and you're not pregnant, then I would, kind of really force the issue and say, yeah, we gotta look at a bunch of things here. But by the time you do your second euploid transfer, you're at about an 83 to 85% probability of pregnancy, which is really pretty good. So fortunately, what I can tell you, even though I sure am sorry you had to go through that experience and not get that positive pregnancy test, but I can say very realistically, the odds are extremely high in your favor that with another embryo transfer, you're going to get the pregnancy. So do you have to do all those things to look at? No, you really don't, because really the odds are stacked right in your favor that it's going to work the second time around. We usually tell folks that we want you to have 2 chromosomally normal embryos for every baby you'd like to have. And that's really the reason why. It doesn't so much soften the blow, doesn't make it easier to go through that process and be excited and hopeful only to find out that the pregnancy didn't stick. So better times ahead, Kimmy. Our thoughts are with you. Let's see. What stim cycle would you recommend for patients with a low AMH and DOR? Would you suggest going to blast and PGD or transfer at day 3? So there are some different ways to think about that. There are lots of different ways to do cycles. I have some nuances that I do in my practice for diminished ovarian reserve that are not possible in bigger places like where you are, Andre. So the individual stem is subject to kind of conversation. But one strategy is to make as many embryos as you can, and then to transfer all those embryos on day 3, because we know that they're not all going to stick. Day 3 embryos have a lower probability of sticking, but you may be making up for that by transferring more embryos at once. And that is one strategy folks use for dealing with diminished ovarian reserve or advanced reproductive age. Now, what's the benefit of doing PGT? Well, if you do PGT and you know the embryo is normal, you know it's going to have a higher probability of sticking. But the biggest advantage of PGT is taking a group of embryos that's this big. Let's say you grow things out to blast. You started out with this many eggs, you made this many embryos, and now you've grown to blast, you've got this many blasts. Well, you can take this many blasts and separate that down into this many PGT tested blasts that are known to be normal or believed to be chromosomally normal. And then they have the highest probability of getting you pregnant. But if you're only making 1 or 2 embryos, I don't think it makes any sense to do PGT testing, because your body's going to give you that same information. Those embryos are either going to stick because they're normal, or they're not going to stick because they're not. So, not a fan of PGT. As we get older, when we have fewer embryos, better to use it to take a larger group of embryos that we've used nature to help select the first group, and then use some science to help select the second group. Well, folks, it looks like we are going to be out of time here tonight. Thank you so much for being a part of my Tuesday evening and for letting me be a part of yours. We are back here every Tuesday evening at 5 p.m. Central Time. I'm on the Gulf Coast here in Pensacola, Florida at New Life Fertility, and also at the Missouri Center for Reproductive Medicine in St. Louis and Tulsa. We are happy to be a part of your fertility journey. Look us up online or simply give us a call. We're part of the world-renowned First Fertility Network and are proud to be here with you. Hey, folks, remember this damn fertility business is not the book of your life. It's just a chapter. That's all it is. And what we are doing here is rewriting that chapter together. So until next time, every step forward with kindness, every step forward with love, and every step forward with hope, because tomorrow is a new day and it is full of all new adventures. Until next week, Dr. Randy Fink, thanks again and good night.